Uh, Thank you so much. Let me save my video. Just one second. Okay, so welcome to all and good evening to all, first of all, and welcome to my session. Before starting itself, I would like to tell something. I have a very bad cough, so in between I may cough also, okay? So first of all, I will just share my okay. So once again, good evening to all. Welcome to my session. And today is about the wound care. So just I will talk about malignant wound first. And let me tell you what is being done over here. I'll be talking to you because you all are working doctors and maybe working in government setup or in in a private sector. In many of the government sectors, whatever the materials we get for the dressings are very low cost things and we make with our own hand. But of course, in private sectors and all, you get it. Commercially made things are being given. Okay. So I'm not going to talk about that things because most of our patients are usually poor patients who come to a government setup or who are in the home care settings. Okay. So what is available in our hands, we try to do it. So when I talk about malignant wound, I hope you all must have seen a malignant wound that also very bad wounds, which is to bleed and at times very malorder and these things. So I just would like to ask a question to you all. When you see first time a malignant wound, what do you feel like? What is your feeling when you see a malignant wound? Anyone can put in the chat box. I think there is answer on pity. Usually secondary infections will be present. Oh, this wound will never heal. Sadness, confused, whether it will heal. Confused about doing the dressing. Okay. So, see, people have different statements. Josna said it is pity to see such a thing. Usually secondary infections will be present. Wound will never heal. Will feel sad. Infiltrate, prone to infection. Infection usually painful. Yeah, a lot of other malorder. It's a lot of answers have come. I don't know why we should feel pity or sadness. We may feel many questions will arise in our mind. We'll start thinking of a lot of things. Okay. But when I see a malignant wound, I look at the patient. I feel for the patient. Say physically, we will be able to do something or the other. What about their psychosocial and spiritual things? It's very difficult. We should not feel pity for the patient. Look at the patient. If you just look at the patient, that itself will teach you a lot of things. So, let us see exactly what it is. It's a primary or a secondary malignant growth in the skin, which is ulcerated, and of course, it is difficult to heal, or more, if I say it doesn't heal. That is the main thing. Okay, so 5 to 10% of the patients with metastatic cancer will develop a malignant wound. So most common sites, what we see is breast, head and neck cancers. Especially if we go to the northeast side, we can see a lot of head and neck cancers. Back, trunk, abdomen, groin, axilla, and of course the genital. Just look at this wound. This is a malignant wound. This patient had come to us with an open wound. She has not covered it. She kept it open and she came. Just tell me, what are the common problems that you come across in such wounds? What could be the common problems that you come across in such wounds? Yeah, bleeding, pain, infection, malodor, pus. Yeah, sure. Smell, maggot infestation. Good, good. Yeah, exudates will be there. Okay, bleeding. So, a lot of things are the cosmetic issues, of course, social isolation. Yeah. So, when a patient comes like this, when we look into that only, these all things will come in our mind. What are the common problems that the patient is facing? Okay. And here we have to see to these things, issues. I think when there is a proliferatory malignant growth in the skin, it causes relatively loss of vascularity, will be the necrosis sometimes, ulcerations, and of course, infection by the anaerobic and aerobic bacteria, which leads to many issues. So these are the problems where the patient is facing. Physical problems, psychological problems, social problems, and of course, spiritual problems. But please don't forget about the financial also. It's very, very important because we may write for commercial products for the patient. We need to find out whether the patient is able to buy it or not, whether it is affordable. So financial is also very, very important. So what are the physical problems? And what all can cause pain in the wound? What can cause pain in the wound? What could be the causes? Any answers? What could be the cause? Disfigurement, itching, and all worsen. Infection could be, yeah. Ischemia, nerve damage, agree, nerve filtration. Again, infections, bleeding. What can cause pain in the wound? First, nociceptive pain. Any other thing? Just think of both somatic and nociceptive. Anxiety. Anna George. Wait. Anna George. Let me tell Anna George and Samishka. Anxiety about what? Anxiety about what? Yeah, Bharat Raman Shekhar while cleaning the wound. Very right answer. Most of the patients are scared to come to the hospital for their dressing because they are scared they will have pain. So the first cause of pain is the pain that we cause for the patient when we do the dressing, the cleaning. That could be anxiety, and that is some of the psychological problems. Okay, that previous experience makes the patient very scared, fear. So that's psychological problem. Okay, so one of the causes, pain, is that we cause the pain. Okay, so first and foremost, that is the pain. So remember this one thing. So pain, physical problems, pain will be the malodor, infection, bleeding, exudates, and of course, infestation with the maggots. Psychological problems, altered body image. Just imagine the wound is over here, your image is changed. Yeah? That disfigurement is there. People won't come near you. Why people, own children, they stay to come near to you. Fear of death will be there. When I'm going to die, how I will die, that's another thing. Depression and anxiety. Many people leave their house. Shame, that stigma, still it is there. And isolation. So isolation, usually I say isolation from the family, isolation from the society. Self-isolation, of course, they get adjusted to that because self-isolation is isolation that I isolate myself. But when there is a family and the social isolation, patients cannot take it. That is the psychological problems. Or social problems, see, family isolation, social isolation, and the stigma and fear of contagion. That is also is there. One patient asked me if I hug my this one grandchild, whether it is contagious, whether she also will get a breast cancer. What are the impact of these symptoms on the family, effects on the family, effects on the sexual relationship, and there will be disharmony in their marital status. Interference with the religious rites. Those who are very religious, not able to do their religious rituals. They can take into mind, maybe this is a punishment from God. And if so, why? Why me? I have not done anything wrong, not guilty of anything. So a lot of things goes in inside the patient other than the physical. Day by day, seeing the wound getting bigger and bigger, that itself gives a lot of anxiety, a lot of other problems. So the main principles of management is the palliation of the symptoms, holistic care, and empowering the patient and the family in wound care. That is very important because the patient is not going to be there till death in your setup. The patient has to be discharged home. So in the home setting, how the patient will be taken care by the family member, and that we have to see. So we need to demonstrate and help the family member to do the dressing so that they can do the dressing in their home setting also. Surgery, you used occasionally to reduce tumor mass, but not always be possible, maybe due to bleeding and infection. Chemotherapy also is used, done. Radiotherapy can be done. These all things you know. So the main, first and foremost, is the assessment of the wound location, where the wound is, the appearance of the wound, the surrounding skin, and for, of course, the potential for complications. These things we keep in mind. And the steps of wound dressing is empathetic and loving care. You all must be knowing now what is empathy. Okay. And if you have empathy, automatically there will be a loving care also for that. And remember one thing, if the patient is coming to your setup for the first time and the patient is having a very bad malodor, please see that provide a good bath for the patient before doing the dressing. Let everything wash out. Second, if there is, you can clean with normal saline also to remove the slab, and of course, to clean it also, saline is used. And a layer of absorbable or non-adhesive gauze to remove the exudates. And apply bacteriostatic drug. So this should be kept in the mind. And of course, you can apply Gamgee pads, secure with bandaging or adhesive tape, and attention to the wound margin healthy tissue. What usually we say is more to secure with the bandaging is that whenever you try to remove an adhesive tape, that wound margin, that skin also will get peeled because it's very fragile. So as far as possible, try to put a bandage. It's better than an adhesive tape. So let us come to the pain first. Okay. If a patient says a deep pain, continuous pain, maybe the patient has left the home around about 6 o'clock something and coming to your setup where the patient has traveled, not taken the medications, and the patient is telling patient is having pain, and exactly the patient doesn't know patient but having pain. Please ask the patient to take their regular medications, wait for 45 to 1 hour, then find out how the pain is, then only start doing the dressing. Just don't give the medication and start doing the dressing. See, the patient, at least a bit of pain should be, we have to minimize their pain and then only start doing the dressing. Many patients complain of superficial pain, that is a pain on the wound, stinking pain, otherwise burning sensation. They will say like a needle prick. Local application of lidocaine. I mean local application in the sense or sensocaine, not injecting. Just soak it in a gumji pad and you can keep it on the wound, over the wound like this. Otherwise, just take it in the syringe and spray it on the wound. Just wait for 10 minutes. The patient will have relieved pain and then you can start doing the dressing. Of course, in some incidental pain, people do try to give sublingual ketamine before, if the patient wants to go to the washroom and the patient knows patient will have pain, they will take sublingual ketamine and that will relieve their pain. And remember one thing, as I told you, previous dressing should be properly soaked and then only removed. Without soaking, please don't remove. If the patient is in the home setting and you're telling the patient, I'll be coming this week, this so-and-so day, tell them to take a thorough bath so that the dressing will get soaked. They can remove the dressing. Just put a layer of dressing on the top of that and wait for you people. So malodor, daily cleansing and dressing is very important. If they do daily cleaning and dressing, malodor can be reduced. Local metronidazole tablet crushed and powdered, we use that only here, and especially if the smell is too much. As I said, malodor is very bad malodor you are having. You can use our injection metrogel IV infusion that can be used as a local irrigation. You can do with that also. The smell will reduce. And if a patient is having a painful wound, metrogel powder can be made a paste with the silocaine jelly and that also can be applied. Of course, malodor, maybe due to infections, systemic antibiotics can be started. And of course, frequent changing of the dressing. So many times it happens, morning the dressing will be applied and next day only they will remove the dressing. So a lot of exudates and smell will be there. So better to, whenever the dressing gets soaked, better to remove the dressing and apply a new one. We come across patients saying that, especially family member, since past 1 week, the patient has not taken food due to the smell. And after coming here and after the dressing, the patient started taking food because the smell has reduced. Both the family and the patient is affected with that. So try to reduce the smell. That is very important. Managing infection, again, daily dressing with metrogel is very important. No slough cutting, no hydrogen peroxide, and no betadine to be used. So managing bleeding, local pressure is the best thing to do. If you see spot bleedings, give a pressure with the gumji pad, otherwise in a pad. Of course, we use one more thing is sucralfate powder. Sucralfate tablet is been crushed and given to the patient. So when I talk about this, please empower the family member that whenever there is a head and neck cancer, especially head and neck cancers, anytime it can bleed off, anytime it will blow out. Okay. So the family should be prepared for that. Ask them to keep dark colored clothes at home. Give them in handy sucralfate tablets or powder. Whenever they see spot bleeding, ask them to put this sucralfate powder on the spot and give a tight pressure, right? Bandage. Systemic ethamsalate also you can give. Systemic in the sense maybe oral or IV, it can be used. Of course, in some cases, palliative radiotherapy can be helpful. But managing bleeding, we need to empower the family member. Anytime the patient may blow out and die, that is very important. Okay. Anytime the patient will blow, this will blow out. And what they will do, they will get this one. They'll put the patient into an ambulance and they'll rush to the hospital. Before the patient reaches the hospital, so the patient will die. So right from the day one, we need to educate the family member, anticipate what could happen in such cases and what they have to do. And that is very important because many times we have come across patient being rushed to the hospital. By the time patient has reached the hospital, the patient is dead. So both the family member and we also will feel very bad that time. It's very difficult to handle such situations. So empowering the family member about that is the realistic thing, what is going to happen is very important. You see can you see how it is oozing? I have seen. I remember one youngster who had an osteosarcoma and he was bleeding like this. So twice or thrice when he had come, he did not bother much because his father told me that doctors have already told to amputate his limb. But he said he cannot amputate his limb because he's a football player. But day by day, when it started bleeding also, and once when he came, he saw the bleeding and it was a question mark question he asked me. We were all standing around him. So he just looked at me and he asked me whether this bleeding could be stopped or not and why still it is bleeding. And before I could answer, he has seen my expression on my face. And he himself told, he never told me anything else. He just told only one thing, turned to his father and he said, Papa, I'm ready for the amputation because I don't want to die after bleeding, it seemed. And he came after amputation, he had come to us also. It's very difficult sometimes. So maggots in wound, that is another thing. Prevention is the best thing that we can do. Now, when I tell about prevention, the area where there is a lot of flies and all, please ask the family member to use a mosquito net. That's one thing. Second thing, always 24 hours, it should be covered. Good dressing should be done. Daily dressing, if there is malodor, use of Metrogyl, changing the wet soaked dressing and applying a new one, that is very important, and it should be covered, well covered for 24 hours. Not to keep it open inside the house, because inside the house also the flies can attract. And this is going to happen. So tell them to keep it always covered. And here what we use is we use turpentine oil. Turpentine oil, please don't use it directly. I mean, 1:1, you can dilute it. And where the wound is there, only on the area of the wound, you can just spray. And especially where there are the pockets, just pour in the pockets. And one more thing you can do, it can be soaked in a gamgee pad and just you keep it over the wound. Wait for 10 minutes. You can see slowly it starts coming out. Just pick it with the forceps and put it in hot water. So hot water should be kept ready next to you so that you pick up and you put it. Because once you pour the turpentine oil, it starts coming out like anything. So we need to be very careful. Physical removal, that is the best thing. And when you do it also, remember one thing, I'll just show some photos. Can you see this wound? This has all come out, maggots in the wound. And here you see, there's no much light over here. Why, whenever we pick up the, when we put a direct light, what happens? It withdraws inside the maggots. So always it should be from the opposite side. The light should come from the opposite side so that these maggots will slowly come out and it is easy for us to pick up. You can see how many maggots has been removed from one. This is just from one patient. And this has to be continued. So every day when the patient comes, do the dressing first and foremost. And now how we will come to know? Sometimes the patient says, this one I'll come back. Sometimes the patient will say, something is crawling inside. Otherwise, they may say the smell has increased. There was no smell, but I don't know. Now the smell is increased. Okay, slowly the smell has come. Some patient they say there was no bleeding, but at times there is something like pricking and then it bleeds. This is where we should have in mind, we should think of maggots. Just take turpentine, dilute it and just spray it and wait for some time. You can see the maggots coming out. So after the maggots has been removed, flush with normal saline, clean with normal. Now when I tell clean with normal saline, never scrub the wound. It will start bleeding. So it is just mopping. Okay. Clean with saline. Then you can put Metrogyl, cover it with the gauze, send the patient. Next day, the same thing like this, at least for 4 to 5 days. Please do the dressing so that all the maggots will come out. And instruct the family member and the patient, it should be kept covered for 24 hours, not to keep it open. This patient was brought covered in a bed sheet by their son. And as they were walking into the corridor, we could see the maggots falling down. So such a big maggots, you can see. And you know what, when I asked them when this started, he said yesterday only. I said, no. I said, this has not it. This has been started. And they were a joint family, 50 people in one house, and they neglected the patient. And the patient was screaming due to pain also. And it was crawling inside. So many, can't just, as soon as we put the patient like this, it started going here and there. It started coming out inside, even inside this lips also it was there. We gave this one morphine for the patient, subcutaneous morphine we gave, waited for some time. Before that only, this whatever was coming out, we just picked it and put it. Then we just soaked the gumchi pad and we had kept it over here. And then we could remove, slowly we could remove it. Their own family hesitate to touch the patient. So it's all because of negligence. If the family is not going to take care of the patient properly, they will land up with that. So we need to empower the family member right from day one. When they come to you, see that the very next carer is standing next to you when you are doing the dressing, and tell them this is how we have to do the dressing. So that fear will go and they will also start doing the dressing. And tell them if they are not going to do the dressing properly, what could happen. The scrub it bleeding. If they don't do the dressings daily, there will be malodor. And if they don't do the dressing, smell will increase, maggots will be there. So these things you need to talk to them so that they will understand it. See these wounds. This patient was not able to open her mouth properly, very little only. And that was a very bad smell. It has made an oral fistula here. So we have kept this one kidney tray over here, took a syringe with Metrogyl diluted and just flushed inside, and it started coming out through her mouth. Then just with the gauze, slowly we cleaned, covered this, and this was how the dressing was done. And see this patient, it's very difficult. So prevention of maggots, daily dressing, and keep the wound covered, use of mosquito net. Then I told you how to do the turpentine oil dressing, okay? And training for the carers is very important. Wound care in advanced cancer is very important. Empowering the carers to look after the patient, to take care of the patient, that is important. Because we are not going to be there with the patient 24/7. They have to take care of the patient at home. So we need to empower them. So training for the carers, knowledge, attitude, and practice is assessed. As I said, give the demo and see how they are doing it. Practical demonstration, regular follow-up, and the realistic goals of care should be given. Improving quality of care and palliation symptoms. Teaching how to make a normal saline preparation at home, saline, and the sterilization of dressing material is also very important. One young chap came, hardly a child, I should say, 16 years. He had a very big wound over here, and he was like this. He was sitting in our this one corridor near to this one. All the people were walking up and down. This wound was kept open. When I talked to their parents, they said he won't allow to cover the wound. And why? Because he had come to the hospital once, and when they removed the wound, this one dressing, it started bleeding. So what he says is, if it bleeds, then I will die. So he said not to do the dressing. He was sent to the palliative care. And I saw people walking up and down were just looking at him. I just walked to him, Then I said, I would like to talk to you. I just went and I asked him one question. Told him like this. I said, can we cover this and keep? He said, no. I asked why. He said, it will start bleeding when it is removed. I said, I'm not going to cover it fully like that. I just want to hide it because dust will be there, everything is there. And if you feel that because of that you're going to have a problem, immediately I will remove also, he said. I don't know why he felt that confident. He said, okay. What I did was I just took a towel, made it in a triangular shape, okay, and I just tied over that. So this was covered. He was very happy, you know. And that boy was admitted in our unit. He was there for quite some time with us. And one day when I went, actually, he asked me to go and meet him. I was given this one, so I just went and met him. That time, full dressing only was done for him with the bandage. So you know what? He smiled and he said, "Here it is. There is no bleeding in same." So we need to talk to the patients. Sometimes our communication is very important. So let us see. Saline can be prepared at home. 2 teaspoons of salt in 1 liter of water, boil and cool it. That can be used. Not one pinch and all. No, please, for heaven's sake, don't ask the patients to do that, family member. They'll just make 1 glass of water to clean whole that type of wound, okay? 2 teaspoons of salt in 1 liter of water, and then boil it. Keep this in a clean container, and they can use it daily. Dressing materials. In many of the missionary hospitals or in the hospice centers, they used cotton clothes. They washed nice cotton clothes like sari, shawl, dhotis and all, which is cotton, washed thoroughly with soap and water, dried and cut into pieces. Pieces in the sense, size of the wound. It is kept in a wide vessel or an idli vessel. Steaming, that's the sterilization, what we do. Every 3rd day we have to sterilize. So after sterilizing, remove the lid. Once it gets dry, keep it in a small container which has a lid. And of course, teach the family member how to do this one hand wash. You have to teach them. Of course, COVID has taught everyone to do the hand wash. Okay, but still tell them before touching the materials, they should wash their hands, not to touch with their fingers. You know, the tongue is the which we use for chapati. Okay, when we make chapati, that tongue they can use. Okay, and they can use one more thing is they can take 2 spoons. That also they can use as a forceps to take out from the bin the sterilized material. Okay, not to touch with the hand. They can keep separate 1 steel plate and 2 small bowls exclusive only for dressing for this patient. Otherwise, they had to buy a tray and 2 bowls with a covering. This is very important. Otherwise, daily, what they will do, they will take anything and they will start doing the dressing. So in order to avoid that, tell them they can use even the steel plate at home, but it should be kept only for dressing for this patient because we can boil also that. Okay, and these things are very important. And dressing material should be sterilized every 3rd day. So today, if they have sterilized it, 3rd day again they have to sterilize it. So what are the aims of our management? Why I came to the last, I will tell you. The ideal aim is complete healing through either local or systemic treatment. But malignant wound, there is no healing. Of course, pressure ulcers, there is healing. So if such treatment is inappropriate, we need to direct to minimize pain, infection, bleeding, odor, maggots, and the psychological trauma of the patient. So give the realistic hope to the patient because the patient and the family, they need to accept it. They will accept it if you do a good communication. And the primary aim is the promotion of comfort and to improve the quality of life. Now, you may ask me, improve the quality of it is not going to, how is going to improve? Even if you reduce the smell and the patient is able to take the food, that itself is the quality of life. Because I know that with this wound, I may die also, but I wanted to eat something. But because of the smell, I can't eat. Because of the smell, I can't go out. That affects my quality of my life. So just give the patient that comfort and that improve the quality of life. So, following the assessment of the problem, choose a dressing regime to meet the needs of the patient. And please, there are no rights and wrongs. Whatever we have to use it for the dressing. Vaseline gloss we can make at home itself. And commercially available products for cleaning are available, but we need to use cost-effective things for our patients. Principles of wound management. There are 3 principles. Treatment of the underlying problem and the comorbid conditions, local wound management, and symptom control. So clinical assessment, documentation is very important. And of course, the evaluation is also very important. And of course, the focus of the care should also include the individual's level of understanding about the wound and their preferences, impact on their quality of life, social and financial concerns, emotional, cognitive, behavioral, mental health concerns, and the impact of the individual's environment of the care also. So there are 2 types that I'm not going into that. I just want to talk about the goals of care is our aim is main for the person's care. And in palliative care, goals of care in palliative care will change over time because day 1 patient won't be the same and the day 3 or day 5 or day 10. So we need to do the review every now and then, and we need to have a care plan. So one is the wound management goals we need. With the burden versus the benefit. You will be learning in the ethical issues and all these things. And modifying any treatment is there. Sometimes, see, the patient is towards the end of life. Otherwise, this is not going to heal. The wound has become more bigger and bigger, and there are a lot of other problems. And still, we are keeping the patient in the hospital, and the cost is every now and then it is increasing. Better to tell the patient's family how to use washed cotton clothes for dressing, what material we can use, and we can modify that treatment. Okay. And of course, appropriate treatment and decision making is very important. And plan it. Symptom management goals are very important. Pain and other physical symptoms has to be managed. And of course, the psychological and social problems also. So again, we need to plan that. Communication goals. We need to sit and communicate, find out what are the present knowledge of the diagnosis and prognosis. And what they would like to know, that also we would. And meaning of knowing whatever we have told them, whether they understood or not, that we have to find out. What they understood of what we have spoken to them. So keep communicating with the patient and then plan next what to do. Decision-making goals are very important because they need to decide whether they want to be at home or whether they'll take the patient in the home setting, who will take care of the patient, who is going to take decision for the patients. These things are very important. And as I said, if there is sudden bleeding, what the appropriate decision-making and planning should be there, what they are going to decide about that, whether they will rush to the hospital or whether they will take care of the patient at home. Practical goals, place of care, where the patient is being cared, the infrastructure, especially the logistics of care and travel. In case of emergencies, whether they will be able to reach out to the hospital or not. If there is anyone to take care of the patient at home, to do the dressing properly, ensure the patient's comfort and wishes too. So anticipatory goal is that, as I told you, you can anticipate if the patient can anytime have a blowout. So in that time, what they have to do. Issues about nutrition and hydration, I told you. If there is a wound over here, it doesn't mean if there's a fistula that you have to put a Ril's tube. Ril's tube is not an option. Patient can cover the wound, and as far as possible, patient can eat. And after that, the patient can be given a good mouth care and put this one bandage over here, dressing over here. So in the end of life care also, please don't stop doing the dressing. We need to do the dressing. And ensure symptom-free and dignified end of life. It's not that when the people come, a lot of smell is the patient is already going and that because they have not done the dressing. No, they can still continue with the wound dressing. So wound prognosis is very important. Can the cause be treated? Anything like any wound which can be treated, that can be treated. Find out them any other medical condition, drugs that do not prevent healing or prevent healing. This also is very important. Some drugs are the which slow down the wound healing. And prevent from further skin deterioration or breakdown, trauma, and wound infection, and promote patient adherence, and optimize the pain and other symptom management. So assessment, whether ask them, have you noticed any changes to your wound and what you have been doing to care for your wound? That's the first time when the patient comes, we can ask what they were doing, how long this wound has been there, what are the provoking and the palliating things. It means what makes it feel better or worse. The quality, do you feel that the plan for caring your wound has been effective, like the type of dressing, cleansing of the wound, whether it is okay or not, that quality. Where it is actually affected, the severity of the pain or the discomfort of that wound, how it is. And does he experience any other symptoms like fever, discharge, bleeding, or odor? Treatment, and how the patient is managing the wound on current medications, how effective it, and if there is any side effects. Important thing is understanding how the impact on the patient. That wound, what's the impact of that wound on the patient and the family in his activities of daily living? What's the impact in their relationship with the family? And does they need any require any support from the home care nursing or from the family? Whether the patient is able to eat, whether the patient is able to sleep, drink. These all things we need to ask the family or the patient, because we don't know what is their comfort goal or acceptable level for these symptoms. Physical assessment, location, size of the area, color, depth, these are very important. Presence or absence of the odor, intensity of pain, if there is any signs of fistula, presence and absence of bleeding, pruritus, we need to find it, and if and effectiveness of dressing protocol. So there are a lot of many types, many companies are the many types of dressings are available in the market. Okay, affordable people, please go ahead. If they are affordable, they can buy and use it. Absorbable dressings are the hydrochloric dressings are available, hydrogel dressings are available, many types of dressings are available, but affordable only to buy it. Because once the patient discharges and goes home, they won't be able to do anything. They won't learn also how the dressing materials are made. So it is our duty to teach them so that they can carry it out when they reach back home. So pain, as I told you, sorry. So non-adherent dressings are very important. This can be made out of the gauze also. So if you feel that our gauze material, what we are making, you can use a Vaseline gauze also on top so that it won't get adherent to that. It won't adhere to that. Okay, it is very easy to remove. Hydrogels, hydrogel just this one, sheet dressings have come. Many types of dressings are there. I've just put it. Hydrochloride dressings are available. Then transparent film dressings are available. We can see also the wound. Semi-permeable film dressings are available. Alignate dressings are available. Foam dressings are available, like for in some cases, the foam dressings they use for even this pressure ulcers. Then autolytic debridement, that usually when we use hydrogel dressings and all, this can happen. That's why I told we cannot cut the wound. Okay. So simple measures, as I said, was commercially available gauze, used cotton sarees can be used. Colored cloth should be kept to mask the bleeding. Vaseline gauze can be prepared by cutting into it, smear it with the Vaseline, pile it in a cooker or in a wide vessel, how to steam it, so that the Vaseline melts and coats uniformly into all the gauze pieces. And this can be used as a Vaseline gauze. because commercially available Vaseline gauze or Chule is very costly. And you can see the wound is so big, how they are going to apply, cover all the wound. It's quite difficult. Then to reduce smell, one more thing is you can use the second or the third layer charcoal. Activated charcoal the dressings are available, but they can make also charcoal if it is available at home. They can use it not direct to the wound. Second or third layer they can use as the. Otherwise, what they can do is, if there is malodor, they can keep in the patient's room, and the corner of their room, they can keep charcoal, because charcoal absorbs the smell. It will reduce the smell. And to prevent the even the mopping the floor with a few drops of ginger grass oil is very important. And the patients who are having rectovaginal fistulas and a lot of smell is there, you can use our usual newspaper, because newspaper will reduce, it has a carbon and it absorbs the malodor. So sheets of newspapers can be kept under the patient's waist. This will absorb the smell. I'll go to the second one. Just so now again, you all know what is the pressure also. When the patient, usually it's an area where the locally soft tissue necrosis is happening if the patient is lying down in the same position for more than 2 hours. There are a lot of causes. Extrinsic factors and intrinsic factors are the pressure, shear, friction, moisture can cause. The other are, comorbidities, nutrition, and advanced age. So weight loss, less padding over the bony areas can cause. Sliding down in a bed or a chair, the pressure on the skin cuts off the blood supply. And this is called shearing. A patient sitting like this and slowly sliding. And what happens? It cuts off the blood supply to the skin. Frictional rubbing of the example, for example, where the wrinkles of the sheet, when we try to pull the sheet underneath the patient, this can cause friction and it can also give an injury. So we can prevent pressure ulcer. The thing is, training the healthcare providers and the family caretakers is very important. Very simple methods. Because the skin is our paramount. So eliminate pressure in areas of persistent hyperemia is the eliminate shearing forces and friction. So just for simple case, I will tell you, teach them how to make an occupied bed. I used to tell the nurses that before the patient gets discharged, see that they learn how to make an occupied bed. Instead of pulling and pushing all the sheets, how to make an occupied bed, please teach them. Teach them all the positions, how to make the patient to lie down in which all positions to prevent the infection, where to keep the pillows, where to keep the pads. These are very important. And of course, patients can be given, if some patients are able to move, means we need to give side rails for the patient so that the patient can move on the bed. Okay. So primary prevention, careful inspection of all the bony prominences. Skin should be clean and not very dry, but dry. Support should be given to the surfaces. Positioning and nutrition is very important. So basics of positioning, when we talk, we can use anything. Air mattress can be used, water bed can be used, foam wedges can be used, pillows can be used to prevent direct contact. Donut type of devices are not being used because of venous congestion. As far as possible, try to position the patient on the sides, but not on the trochanter. Head of the bed as low as possible. We say 30 degrees. I will show you. And do not drag the patient while transferring. Okay. Use mild cleansing agent in the sense like soap should not be applied directly on the body. Apply to the palm, then only apply on the body. Moisturizing agents can be used so that it prevents any loss of moisture and hydrate the skin. Soon after the bath, tell the family member in a bedridden patient or in a patient who is sitting. Soon after the bath, as you wipe with the towel, after that, immediately apply moisturizing cream. If moisturizing cream is not available, they can use even our oil, like coconut oil or some cooking oil they can use to keep the body moisture. Best is coconut oil. Okay. Topical agents can be also used. Glycerin is very good. Keep the sheets dry and wrinkle-free. Maintain current levels of mobility. I tell the patients, family, and the nurses, let the physiotherapist come, teach them all the exercise, okay, and let the family member learn it, and after that, they can do it. No need of physiotherapist till the patient is alive, okay? And avoid massaging body prominences because it will cause an injury. Glycerin is very important and commonly used moist ingredient, okay, because it improves the skin hydration. Other than like even petroleum jelly, people use, we use here liquid paraffin also, that is also good. So positioning, lying down position every 2 hours. By 2 hours, the patient's position has to be shifted. And if the patient is in a sitting position, every 30 minutes, the patient need to relieve the pressure. This position, 90 degree, it's not good. Best is 30 degree, but you can give even 45 degree also, but 90 degrees is not good. See, this is a foul is 45 to 60 degrees. Okay. And the best position is this. So not much of pressure in this area. So when a patient is on the semi-fowler's position, see where all the pillows are. If pillow is not available, they can keep even fold a this one cloth, okay, bed sheet or something, and they can keep. This is the under the arms, you can see near the elbow, sideways. Why? If they can keep the arm like this, and of course under the calf muscles. When the patient is on a lateral position, this is a full lateral position, patient is lying down. Okay, see where all we have to keep the claws in between the this one knees. That's very important. Side lying position, Sims position we say, you see, here, 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 and here. So when we talk about stages of pressure, how many stages are there for the pressure injury? Anyone? How many stages for pressure injury? No answers? Any answers? That's a one answer has come. Let me see. Oh, Dr. Pooja has said 4. Okay. So let us see. So the first stage is the mildest. It discolors the upper layer. Okay. Usually the color changes. Okay. So the best thing what you have to do, because the surface is not broken till, okay. So it's just there will be redness, but the skin is intact. Okay. Relieve the pressure. That's the first thing you have to do. Relieve the pressure from there. No need of giving even dressing. Okay. So see that the patients do have good food high in calcium, protein, and iron, because this food helps with the skin to keep the skin healthy. When you talk about the second stage, the top layer is already, there is a break in the top layer, that is epidermis or the dermis. Sometimes it will be filled with the serum filled, and it can form a blisters also. That blister will break. Okay. So you see, this is already broken. There is a epidermis and dermis can. So blisters will be the shallow ulcer can be the, just clean with normal saline, put a simple dressing, that is enough. Relieve the pressure. Now third stage, full thickness, that is up to the subcutaneous tissue, it has gone. Exposing it, okay. There may be minimal slough will be there. Usually with syringing, maybe the slough will go. Clean it properly. You can see that it's healthy still. Okay, clean it properly, relieve the pressure, give a good dressing. And one more thing is nutrition. Just see whether the patient's HB is okay. How about the electrolytes? These things are very important. Many times in bedridden patient, why this doesn't get healed, not even bedridden patient, even the diabetic ulcers also, HB will be very low, so it won't get healed. We'll be doing the dressing patient is at home, otherwise bedridden. We don't bother about that. So just have a look, at least in the 6 months in a bedridden patient, have a look at their HB. How is their serum electrolytes? That's very important. This is the 3rd to 4th stage, because you see the wound. Necrosis is there little bit. There's a slough also. Some areas it is pinkish. This patient was on air mattress and still developed a this one, pressure injury. And this side you see on the trochanter, there is a black. This is the eschar. This is unstageable. Otherwise, the 5th stage, we don't know what is inside. Unless you remove that eschar, you won't come to know. This we need to clean. Can you see here? There is a hole. If you put your finger, the finger will go inside. It's just like a tunneling. So in these cases, what we need to do is, if there are like this places, we need to fill that gap also. Clean thoroughly with the this one. Here again we do metrogel also, but things are available in the market. We can use some other this one, antiseptic ointments or something, antibiotics. Okay. And if you feel the patient needs some antibiotic due to infection, you can start off with that. Main thing is incontinence of the motion and incontinence of urine, that we have to keep in watch. Okay. So antibiotic therapy and specialized matters can be used. Okay, now the 4th ulcer, completely we can see. You see the bones, muscle, bones, joints, everything we can see. It has gone deep. Okay, here what we have to do is, packing is very important. Just don't clean it and cover it with one ganji pad. No, packing. And packing also not too tight packing. Little bit, what to say, mild packing should be there, because the air should go inside. Okay, it should be airy. Too tight packing is not good. How we pack for the perineal abscess and all, and there is a hole, we pack. No? So ribbons can be made and we can pack it. Okay, and then on top of that, you can apply a gumji pad. And if there is too much of oozing, see that it can be. See, this I am talking at a level where a patient is being looked after in a home setting and all. Okay, things are available, but vac is available, so that you can put the vac machine. It will start this one, what to say, suctioning whatever exudates are there. It can heal also. Okay, but it can be done in the hospital. People who are affordable, they are doing it also. Plastic surgery patients, other there is no comorbidities. The rest of the things are good. Patient can go for plastic surgery also. But where it is not possible, there we have to act like this. Okay, I can say 4th stage pressure ulcers we have healed. So that's why nutrition is very important. Protein nutrition is very important. Relieving pressure is very important. Good dressing. These 3 things you do, the ulcer will heal. I'm talking about not about the patient who are in end of life and these things. Okay. So this can be done. You see, this is this side you can see. Okay. So here we don't know, and this is unstageable. Why? After you remove this only, you will come to know how deep it is. And this is very dried one. We have to give moist dressings 3 to 4 days so that it becomes moist. And then we can, at one stretch, if you start cutting, the patient will start bleeding also. So in the home setting, we never do one stretch cutting. No. Because the patient will start bleeding. And many times we need to reduce their pain, etc. Then only we will start do the dressing. Okay, nowadays they are doing another thing is vinegar dressing. They are also doing vinegar. They will just soak and keep it on this place. Okay, and once it becomes moist, it's easy to cut, because when it's dry, it's very difficult to cut. There can be suspected deep tissue injuries. You must have seen such things. Once this comes out only, you will come to know at what stage it is, underlying grade 3 or 4, whatever it is. We cannot make until unless this is there. Okay, so this is also very important when there's a deep, suspected deep tissue injury is there. See, like unstageable, very black. So that is why patients, this one heel has to be relieved from pressure. We can keep small rings on the heel so that the pressure is relieved. If the patient is in the air mattress also, the patient is in the water bed also, okay, at least ask them to change the position of the patient at least within 4 hours. That is very important. So a lot of stools are the Norton scale, Braden scale, water flow scales. Usually everybody use is a Braden scale. Okay. So there is a 5-pillow rule. 1 pillow under the legs to elevate the heels. 1 second pillow between the ankles if on side. 3rd pillow knees if on the patient is on the side. Pillow behind the back unless you are using the turn and this one. Otherwise use a pillow at the back and pillow 5 under the head. Rule of 30 is head of the bed should be elevated not more than 30 degrees. Even if the patient is watching or eating and all, see that as far as possible only up to 30 degrees. And even if the patient is on the lateral position also, okay. If the patient is really going to sleep in the night time, you can just put on the flat one in the sense slide lying position. Otherwise, put on the lateral side with a 30-degree inclined position. Okay, this will relieve the pressure from the hips and shoulders. And never place the patient directly on the trochanter. Okay, so maintenance of the skin integrity is very important. I said daily bath, apply moisturizing cream, improve the patient's nutrition and hydration, use any of the pressure relieving techniques, promote movement for the patient, educate the patient and the family. And about the exercise also, you have to take exercise and massage is very important. And again, to prevent, place the patient's cot at the window side. I will just show you. Keep the patient always on the window side so that the patient can hold on to the rails. And when the patient feels warm, patient will automatically change. Many times patients are put on in the center of the hall or in the center of the room where they won't be able to turn if there is no side rails. Otherwise, patient should be put on a side rail cot. Overhead bars are very good so that they can hold it and they can relieve the pressure. This is all for the bedridden patients. Backrest can be used for the patients. See, the cot, which can be adjustable cots are there, well and good if they can buy, but the normal amount, I'm talking about the poor patients and all, they're adjustable. They cannot get it, means best to put the patient on the window side. They can at least watch outside. They can hold the rails and they can turn the position. On one side, you can put a bar for them so that they can hold that also. And backrest, it's not so costly, but of course, if the patient is not able to buy it, they can use pillows at the back so that the patient can sit. Air and waters, I'm not going into detail of that. Okay, this is the so how to make Vaseline gauze? I told you, take Vaseline, cut into pieces the dressing materials. Okay, nicely smear the Vaseline into the gauze piece and pile it up. You can autoclave machine, okay. If not autoclave machine, sterilize it, as I said, in a wide, wide vessel. Okay. So what happens from the top, slowly it gets on uniformly, it will get smeared on all the gauze, and this can be kept and used for the dressings. Yeah, hydrogen peroxide and betadine. Betadine we won't use because I don't know this one. It gives a very bad smell, betadine, and the color itself. When you put betadine, the color itself, sometimes it's like what to say, like bleeding. And the third thing is it inhibits the growth of the normal tissues. Studies have been done on that, so we don't use betadine. It's got a irritating what to say, it gives some irritation. I don't know how many of you have used it. Okay, now again hydrogen peroxide. Hydrogen peroxide also, it's very irritating, somewhat burning sensation. Okay, so these things better not to use for these patients. Just go for simple saline. Most of the places now, I think everywhere they are using only saline for the dress cleaning. So use saline. Saline is very good. Yeah, no one should suffer means you need to educate the people who are coming to you with their family member not to use this, what is that, gutka and tobacco and these things. That is very important. Please, in your clinics, please put up some photos, pictures of these things. And write in there, means wherever you are in their own language, just put right in writing that if they are going to use tobaccos and all these things, what will happen. So let them see the pictures at least. Yeah, of course, as yesterday when I was taking, someone said after seeing also some people don't listen to these things. They still carry it very lightly. But from our side, what we can do is put these pictures in your hospitals, in your premises, where in your clinic, so that you can teach them. Yeah, Biju Jacob has said, see, toxic effect. We don't use betadine because it's not good. So talk to the patient. Communication is very important. One of our patient was literally coming to us from very far daily for dressing. Wife, they had a very small shop and their livelihood was on the shop only. And we have taught that everything to a wife also, but he never allowed, saying that if the sisters touch, it will heal itself. And finally, when the patient had come, we had to explain to the patient in a very good way. We sat and we spoke to him that this is not going to heal because it was so small. Now it has become so big. And another thing, second thing, what we told him was, your wife, she has to look after not only you, she has to take care of the shop also. And every day she's coming to you. She can take care of your wound because we have taught her. Okay. And then finally he agreed and he was taken care of by his wife. So teaching the family member is very important. Because many times what we do is we do the dressing and finally while going home, we say you have to do the dressing at home, but not in palliative care. Palliative care, we teach the family member, empower them, educate them well, so that they can carry out their dressing at home. They can prepare their own dressing material. They can prepare the saline. And also they can take care how to dispose these things. We need to teach the family member. Okay, people living in the urban areas are finding to come difficult to come to the home, come to the hospital, because such a small wound, when it becomes very big, it's very difficult. Now you see a patient with pressure injuries. Okay, once the patient become bedridden and with a pressure injury, how they are going to come? It's very difficult for such patients. Putting this one, they have to change their catheter, maybe they need to change their Riles tube, something will be there. But for them, it's not affordable. Even for rich patients, very difficult because somebody has to bring these patients. And these things we can do in their home. So we need to teach them about any care. We need to teach the family member so that they will take care, empower them. Once you empower the family members, they do it. They won't be scared. The thing is, they are never shown the wound and nothing is being shown. So they get scared of it. So while doing the dressing, see that the patients are next to you so that they will come to know how to do the dressing. That is very important.
Okay, thank
Yeah,
you, ma'am.
1:1, turpentine, 1:1. Anything else? How to discard the dressing at home? Say here in many of the home care settings, what they do is they do the dressings. They take this one, everything is being put in a paper and they burn it. Okay. Some places, of course, where there is a very good disposing, what to say, the municipality and corporation they are having, they're disposing in that way also. But the people in the home settings, you can ask them to this one, burn it. That is the best thing they can do. Not even to tug it and put it in and just under the mud. No, nothing. Burning is the best thing to do. How to prepare sucralfate powder? Simple. Sucralfate powder tablet is available. Just crush it. What we do is, like, especially these head and neck cancers and all, we give to the family member the sucralfate powder tablet. In some cases, if they are not able to powder it, we powder it and give them. Tell them whenever while doing dressing, if you see a bleeding point, put the sucralfate little bit and give a dressing. That's all. Any other questions? You can this one dilute the turpentine with the saline itself.
Okay, ma'am, there is a case presentation by Dr. Leah.
Yeah. Let them do.
We can come after that. Dr. Leah, over to you.
Good evening, everybody. I'm Dr. Leah. I'll be presenting today's case. This is a patient who is 69 years old, a male patient who is diagnosed with CA buccal mucosa. Presenting complaints, he had wound over the right cheek, which was foul smelling with maggot. It was infested with maggots and it was associated with pain. And there was also fistula formation. And he had generalized weakness and difficulty in swallowing food. History of his illness. He was apparently all right 1 year back. Then he experienced toothache and right cheek swelling, for which he went to a dentist who advised him to consult a physician after seeing abnormalities in his reports. His biopsy report showed leukoplakia or atoplakia with malignant transformation with an impression of possibility of well-differentiated low-grade squamous cell carcinoma, which was later confirmed to be well-differentiated squamous cell carcinoma, for which treatment was suggested. Patient decided to undergo Ayurvedic treatment, which he didn't follow regularly. Later, a wound was formed on the right side of his chin, for which he consulted allopathy doctor, and later he underwent 2 cycles of chemotherapy and 10 cycles of radiotherapy. Meanwhile, he developed multiple lesions on his cheek, which later joined together to form a big lesion. Due to his poor wound care and hygiene, the wound became foul smelling and it was associated with bloody discharge. Later, it became infested with maggots. Afterwards, he was admitted in a palliative care center where his pain was managed. Proper wound dressing was done after the removal of maggots. Next slide, please. Examination. The general physical examination. The patient is bedbound. He's poorly built and nourished. He's conscious and oriented to time, place, and person. His vitals, BP was 110/70, pulse rate was 75, his respiratory rate was 20, temperature he was afebrile, he had pallor. On systemic examination, his S1 and S2 was heard, normal vascular bed sounds were heard, and Histological examination showed no focal neurological deficit. Local examination of wound over the right buccal mucosa through which inner part of the oral cavity is visible. That is, a big fistula was formed. The lesion is of approximately 7 into 5 centimeters. Initially, the wound was infested with maggots, and later foul-smelling discharge also was associated with this wound. And wound was managed, maggots removed, and clean and proper dressing done. During the course of his stay in the center, the upper lip and a bit of his lower lip had fallen off. Currently, his wound has shrunk and there is no foul smelling discharge. Next slide, please. Treatment and significant investigation. Routine blood investigations were done. Biopsy and histopathological studies confirmed well-differentiated squamous cell carcinoma. He consulted an Ayurvedic doctor for which treatment for this disease, and treatment was started, but he didn't regularly follow the medications. When his condition worsened, he consulted an allopathic doctor and underwent 2 rounds of chemotherapy and 10 cycles of radiotherapy. His hemoglobin was 8.9 gram percentage, and his TLC was 7,200 cells per centimeter cube, and platelets was 4.2 lakh per centimeter cube. Sodium was 131, potassium 4.2. During chemotherapy, he was treated with injection Dexona, injection Pantop, injection Granicit, and injection Carboblat. Psychosocial aspects. The patient is a widower with no children. His younger brother also died due to cancer. After his condition worsened, his sister-in-law and his sister took turns in looking after him. He was a very active, neat, and independent person. The disease made him bedbound and dependent on others, which he is not happy with. He was a smoker and consumed alcohol. He rarely drank tea, but after his condition worsened, he is not able to eat solid foods, which made him dependent on tea and biscuits. He wished to get well soon and eat good foods. The current medication that he is taking: tablet morphine, tablet dolo, tablet pantop, tablet pregabalin, tablet metrogyl, tablet alprax, tablet dulcolax, syrup clemafin, syrup sucralfate. Main concern: patient believes that he will recover fully and has a long life. He is recurring to get discharged and go home. He agreed to come for dressing regularly once he gets discharged. He wished to travel, go for a walk, and eat good food. He is frustrated on being bedbound. He doesn't wish to be a burden to his family and hopes to recover soon and do the things independently. He has financial problems and he is afraid that his wounds will get infested with maggots again. Summary: a 69 years old buccal mucosa cancer buccal mucosa patient presented with painful foul-smelling wound infested with maggots on his right cheek, which rendered him unable to eat proper food and talk clearly. He was in extreme distress, but conscious and oriented to time, place, and person. His wound was cleaned, maggots removed, and sterile dressing done. He was put on antibiotics and pain medication, which helped him a lot. He underwent 2 cycles of chemotherapy and 10 cycles of radiotherapy. He promised to come for regular wound dressing even after getting discharged. Discussion point: importance of proper wound management. Different methods of maggot removal. Do we need to provide palliative care for this patient? Thank you. And the questions are open for discussion.
Dr. Leah, you can say importance of the proper wound management. Why is it important?
Yeah, because of the wound, the patient is in extreme distress. If his wound was properly managed, then he could reduce the distress he is in, like pain and embarrassment that he is facing because of his wound. Then if his wound is properly managed, to some extent we can heal. When those malignant wounds are not actually unhealing wounds, We can, to some extent, we can reduce or shrunk the fistula, and he can take proper foods.
The patient was the patient was having some, I mean, was in rice tube or was eating.
No, he was drinking tea and biscuits. He was not comfortable putting rice tube.
Yeah, they can do even one thing. The patient wants to eat, as you said, the whatever food is there, it can be mashed nicely and can be given to the patient. Okay. The second thing, as you said, there was a fistula, right?
Yeah.
There's a fistula. I told you, na, just cover the fistula with the dressing and ask the patient to eat food. Okay. Okay. That can also be done. And if the patient can use straw, they can make soups for the patient. And usually what we say is, whatever the food the patient likes, in front of the patient itself, please cook this food so that he will see what he is eating. Okay, then proper, if you do a proper wound management, malodor will reduce, exudates will reduce, infection won't be there, and the patient also will feel better. Okay, different methods of maggot removal. Any other methods?
We can use ivermectin topically and local application. Local application, and we can take the tablet also.
Yeah, okay. I don't know. In one of the this one, and I went to I mean, one group of doctors and nurses who had come from Sri Lanka. They said they are using this one, our 25%, 50% glucose to remove the maggots. But only thing, we have to be careful with the patients who are diabetic, and we tried also. I have tried for one patient to say, who had a patient had a cervical cancer, and inside the vagina there were maggots. This happened, why was the patient had gone to somewhere in the hospital or this one, they gave turpentine. I don't know whether the patient family did or the hospital did. They have poured the turpentine, and there was burns all over that pubis area. It was burnt. I have the photo still. Okay. So then, and we could see the maggots out. So then suddenly that struck my, strike that we can use, we will try to use this one, glucose. So we took glucose, and with a small tubing, we had just pushed little bit of glucose. We applied on the outer part of the vagina. No? There all we applied. We waited for some time, and we can see slowly the maggots was coming. We were able to remove some 5 to 6 maggots also. Then we had to give a proper wash with the saline. Okay. There they are not using turpentine, they are using this one. Okay. And one more thing is, even if you cover this one, the wound with the dark colored clothes, because it becomes dark, so slowly this one will come out. But turpentine is very good. Only thing is, dilute it and directly on the wound only you should apply. I've seen 2 patients. One was the cervical burns, which has come due to turpentine. Another patient who had a breast cancer with maggots. They poured the turpentine and the good skin was burnt. So we have to be very careful. Any other methods anyone is having, please do share. Yeah, very right, Dr. Das. Provision of goals of care and improving the quality of life is very important. Now, why this question? Do we need to provide a palliative for this patient? Dr. Leah.
Yeah, actually, it's just a wound management. No? So people will have doubt why we need palliative care for this patient.
Yeah, very right. See, palliative care, we say we can go with the curative care also. Many times patient may be coming for dressing, that's a patient may be going for a chemotherapy or radiotherapy, that doesn't matter. But psychological support, social support, spiritual support the patient will get, that is very important. Just looking onto only the physical symptoms of the patient, usually it lands up with a lot of problems because we don't address their other problems. So if you address properly the patient's other problems, the patient will get adjusted to the disease process and the ongoing whatever management we are doing. That is very important. Yeah, when it is a recurrence of wound, what you would like to know? Recurrence of wound. If it is a recurrence of wound also, same management only we can do. Because we can't help it. Once the wound has come, wound has come. Some people come back saying that it is recurrent and have important wound is there. But same strategy, do the dressing properly, communicate with the patient and the family. Communication is very important because they have that fear and the scare. See, no one says that they won't die. They also know that they will die. But the scare is what you know, how I will die. That we also don't know how they will die or when they are going to die. Okay. But when you approach the patient, we have that empathy in you, you approach the patient, do the dressing, minimize their pain, talk to them, that relieves a lot their, that anxiety and fear in them. And if you tell the family member not to isolate the patient, that is another thing. So once this, this malodor and all reduces, decreases, okay. If they do proper dressing, it will reduce, there won't be smell. So not to isolate the patient, let the patient come and sit in front and all. Only thing is, give a good dressing. In Northeast, I have seen, they use mask also. If the dressing is over, just like a mask, that they cover on top of that also, so that it is not viewed by the public. Okay. And tell them, even if they are inside the house, not to keep the wound open. Some people think if they keep the wound open in the house, there is no problem. Only when I go, I have to cover it. No, it should be covered. Even after making a tracheostomy, there was a wound, and from the tracheostomy came maggot. So much of maggots, because they never covered the tracheostomy area. That is very, they have to cover the tracheostomy area. So these things have to be kept in mind, and all these patients need palliative care. Let them go for their this one, maybe chemotherapy, whatever it is, but they do need palliative care also. Okay. So if there is no any other questions, can we? So once again, thank you all so much. And bye.
Thank you. Thank you.
Thank you, ma'am.
Thank you very much, ma'am.
Bye. See you all.
Thank you, Dr. Leah, for the case as well. Thank you all for participating actively. Thank you. Let's see you in the next session. Bye.